Awesome. So without further ado, let's get to it. So again, we're going to go through a structured approach to neck mass or lump, and there's many different diagnostic frameworks that we can use to approach the neck mass or lump. So I will go through a few different structured approaches, and it's really going to be up to all of us to figure out what works best for you, right? There's not a one size fits all when it comes to clinical approach to a certain condition. It's about figuring out what's going to work with your brain, how you're going to remember things. Again, getting into diagnostic imaging insights and interpretation with these neck masses and lumps, which are very common in primary care. And then what do we do with all those thyroid nodules, right? Over the age of 50, about 50% of people will have these incidental thyroid nodules found, whether it's on CT or a neck ultrasound. And it can be kind of dicey to keep following up with these patients. When can we stop following? What's a concerning nodule? What's a less concerning nodule? So we'll get into the management for that because it's super common to find this in any primary healthcare setting. So starting with the case, we're going to have a 50-year-old female coming in with a palpable lump on her neck. Okay, so it's palpable by her. You can also feel it. So where do we go from here? How do we make sure that we have a structured approach so that we're not missing those really sinister, sometimes sneaky causes of neck mass? So three kind of major diagnostic frameworks you can use is you can obviously think about anatomy, right? The lump based on anatomic location can give you a lot of clues as to what it might be. Then we can think about duration of that lump. Is it acute, subacute, or chronic? That can give us a lot of clues as to what it might be. And lastly, we can think about, different mechanisms that can cause neck mass. So let's get into it. So with anatomy, I'm a very visual person, so I personally like thinking about an anatomic approach to neck lump or mass because it can really tease out benign causes versus more sinister causes. So looking at this diagram, we can first start with lateral causes of neck mass. So if you're seeing a patient and they're coming in and they're palpating and feeling around the lateral side of their neck, we think commonly of branchial anomalies. So these are anomalies that patients are typically born with. Sometimes they can be small, insidious, they grow over time. They can cause issues and require surgery down the line. These can be cysts, sinuses, fistulae, etc. Then squamous cell carcinoma is a fairly common diagnosis in the head and neck. So squamous cell carcinomas can really be anywhere in the aerodigestive tract, meaning they can present in the pharynx, the larynx, the upper respiratory tract, the upper GI tract, and they can present as the palpable lump laterally. With the branchial anomalies, they're typically along the sternocleidomastoid muscle, so that's kind of an easy clue for that. And then we think, secondly, midline masses. So midline masses, we right away think of the thyroid gland, right? Patients can present with thyroglossal duct cysts. So again, that's a congenital anomaly that usually presents in childhood and it can progress into adulthood. They're usually red, hot, sometimes painful, right over the thyroid gland. Then, of course, we have our thyroid nodules, thyroid or parathyroid cancers, at goiters and laryngoceles, which are fairly rare. Then, of course, we think about lymphadenopathy, right? There's lots of nodes that can react in the head and neck region. So based on their location, it gives us a lot of clues as to the etiology, right? We think of the submandibular region, for example. So if the lymph nodes are flaring up in that area, if they're acutely swelling and they go away, likely something infectious, whether it's infection of the oral cavity or a dental infection, those can flare up. Or of course, oral cancers. If those lymph nodes are persistent, lasting 4 weeks, 6 weeks, longer than that, then we always, have a higher index of suspicion of something more sinister happening with those lymph nodes. Then, the cervical chain, of course, we regularly palpate lymph nodes in that region because there's lots of different upper respiratory tract infections, mononucleosis, strep infections that can cause those lymph nodes to react. And of course, again, if that lymphadenopathy is persistent, it's not going away, maybe, the lymph nodes are getting larger and then we can't explain why, then again, our pretest probability is going to be moving a little bit closer towards something more sinister, whether that be something like TB, HIV, more of a concerning infection, or of course, cancer. And then, as we know, the supraclavicular node area, when those lymph nodes come up, we never feel super comfortable because that can be a sign of malignancy, right? Typically, right-sided supraclavicular node, we're worried about, lung malignancy. Left side could be more GI related. So we're aware of those concerns as well. And then, of course, thinking of anatomy, there's a lot of different skin conditions that can pop up on the neck or anywhere on the body, right? One of them, the more common ones being lipomas, which are benign subcutaneous, masses that show up. They're soft, they're squishy, they're mobile. And typically patients don't have any systemic symptoms or localized symptoms. And they'll either shrink or go away, or they'll grow and sometimes get infected. So always thinking of a few of those other common skin findings that we might run into. And the more lipomas you see, the more comfortable you are at diagnosing them for sure. And then lastly, carotid body tumors are super rare, but they'll present, of course, over the carotid artery, and they're felt as pulsatile masses. So that can be another etiology of a lateral neck mass. Those, of course, we wouldn't want to miss. They're rare, but again, pulsatile mass in the lateral neck, think of a possible carotid body tumor. So besides the anatomic framework, sometimes it's easier for us to frame it as, is this an acute mass? And if it's acute, most likely infectious in many ways, right? That might be an abscess that's warm, red, painful, fluctuant, maybe purulent. It can be, again, lymphadenopathy that's responding to an acute infection. And then that lymphadenopathy that's not going away may be associated with more systemic symptoms like weight loss, drenching night sweats, a more generalized lymphadenopathy, then we're more worried about things like HIV, TB, etc. For subacute masses, we're kind of, again, getting into the territory of potential squamous cell carcinomas and other head and neck cancers. So they don't come on super fast. They can be a bit more slow growing and insidious. But again, these are lumps and bumps that aren't going away. And, patients are presenting with likely other symptoms like dysphagia, referred otalgia, hoarseness, vocal cord changes. All of those things will increase your pretest probability of something like a head and neck cancer. And then, of course, I've already alluded to, other cancers like lymphoma, there's sarcoidosis, amyloidosis that can present with masses that are not going away and they're lasting longer than we would like. And then lastly, we think of our chronic bucket. So majority of thyroid pathologies, aside from the very aggressive cancers, will be growing at a fairly slow rate. We think of certain types of thyroid cancers, thyroid nodules, they're pretty slow growing, and patients often present to us, after a couple of months, right? I felt this node here for a while, it's kind of growing, I want to get it checked out. These are typically painless, right? So patients often don't present unless something's, more painful or symptomatic. And then less common but chronic etiologies, I already mentioned, lipomas, they're kind of slow growing. They can get bigger over time. We think of those thyroglossal duct cysts and other anomalies. And then the carotid body tumors, again, slow growing pulsatile masses. And then parathyroid cancer. I would say with parathyroid cancer, usually people aren't presenting for the first time with a palpable lump. If anything, they often present in a hypercalcemic crisis needing urgent management. But just something to keep in the back of our minds if we're worried about that, thyroid, parathyroid region. And then lastly, if you like to frame your differentials more around mechanism, so what is causing the neck mass, then this is another structured approach to figuring out what differentials we want to think about. So for example, could it be an inflammatory or infectious mechanism? So we already touched on that quite a bit, but thinking about reactive lymph nodes responding to various infections, mono, cat scratch disease, TB, HIV, again, already alluded to skin abscess. When you've seen enough skin abscesses, you're fairly confident in that diagnosis. Malignant, of course, we have a low index, high index of suspicion, I should say, if patients are presenting with more localized symptoms, again, that dysphagia, referred otalgia, hoarseness, vocal cord changes. Again, it can be kind of a slowly progressing, insidious thing that we want to keep track of. And of course, lymphadenopathy that's not going away that we can't explain. We have to kind of go searching in that head and neck region if there's a skin cancer, a cancer of the oral cavity, and then sometimes do that imaging if we're worried about a head and neck cancer. And then structural, it kind of ties in the anatomic approach to this mechanisms. So it's again thinking about the thyroid gland, the parathyroid gland, thinking of the head and neck. Is it an injury, muscle, or spasm? Usually they don't present as big lumps, but it's something to think about. Again, those anomalies that patients are born with, the branchial cleft cysts, the thyroglossal duct cysts, and then all the skin conditions that exist out there, right? Teratomas, dermoid cysts, lipomas. And then that other bucket is just typically for things that don't quite neatly fit in the other mechanisms. So things like swollen salivary glands, parotid gland swelling, and vascular malformations like aneurysms or hemangiomas. Those are typically, either cherry red or like bluish in hue. And again, patients are often born with those anomalies, but sometimes they can grow over time. So again, with these different structured approaches, it's not a one size fits all. It's kind of figuring out in your mind and reflecting on cases that you see in practice, figuring out what your brain's going to remember, how you're going to recall this information so that you're picking up on the majority of concerning etiologies and common etiologies, right? This is, of course, not an exhaustive list, but it's most of the main ones that we can run into in primary care. So, diagnostic imaging considerations, I've definitely been stumped on this before, right? Do I order a thyroid ultrasound, a CT with contrast? Should I go right for a lymph node biopsy? So, I had a good discussion with an endocrinologist before this presentation, and a key piece of advice they gave me is when we're thinking of medial or central neck masses, a good go-to will be a thyroid ultrasound because that's majority of the concerns in the central neck, right? We think of thyroid pathology, parathyroid pathology. When we're thinking lateral neck, when we're moving out, then a CT is usually going to be your diagnostic test of choice because we're thinking of other etiologies outside of that thyroid gland, right? The carotid body tumors, the head and neck cancers like squamous cell carcinomas, etc. And CT, usually with contrast, is going to be better at picking up those conditions compared with that thyroid ultrasound. So getting into a few examples here. Again, if we're palpating lymphadenopathy, they clearly have a recent infection or current infection. We know they're reactive. Imaging's not generally required, right? At times, if we're dealing with maybe certainly an abscess in the head and neck region, a large abscess that we want to assess the size, the depth, we're going to be reaching for that ultrasound. Personally, I'm not touching an abscess on someone's face or neck. I'm definitely referring those people anyways. Again, with an acute infection, reactive lymphadenopathy, we're usually not going for any imaging, right? When we have an intermediate or high pretest probability of a head and neck cancer tumor, whether it's metastasized to the neck, whether it's a primary head and neck tumor, squamous cell carcinoma being one of the most common, we want to go for that CT angiogram because it is going to be best at assessing the size, the depth, the location, the characteristics of that mass. And with the contrast, if you're able to order that for your patient, it can differentiate, normal lymph nodes from abnormal lymph nodes, lymph vessels from other blood vessels. So, we think of our carotid body tumors, we absolutely need contrast to assess that blood vessel, right? That being said, when we're looking at the Canadian Association of Radiologists guidelines and the American College of Radiology guidelines, if you have a pretty low pretest probability for a head and neck mass, you don't think it's a cancer, let's say it's a young patient, they have no risk factors, they don't have any local symptoms like the dysphagia, otalgia, hoarseness, It's very reasonable to start with a neck ultrasound, but you want to be fairly clear on that requisition, what you're looking for, what the symptoms are, what area you want the tech to target, because they might miss what you're looking for if they go straight for the thyroid. So again, low index of suspicion for cancer or something concerning, you can start with that ultrasound, but intermediate to high pretest probability, you should probably reach for that CTA because again, we don't want to delay the diagnosis. We know that, at least where I work, it can be 1 to 2 months for an ultrasound. And if that ultrasound gives me a false negative result, it doesn't pick up on a head and neck tumor, then we have to order a CT, and that could be another 1 to 2 month wait. So I'm always kind of weighing that in my mind as well. For congenital neck masses, so again, the besides the thyroglossal duct cyst, any of those branchial cleft anomalies that you might palpate along that sternocleidomastoid muscle, again, CTA is ideal because it is better at characterizing what that tissue is made of, what type of anomaly it is, whether there's sinus tracts, fistula. It's going to be better at assessing the size, the extent, and the depth of that mass as well. And as I alluded to earlier, any thyroid gland pathology, parathyroid gland pathology, we're going to be reaching for that ultrasound. Superior to CT in this case because it's much better at differentiating benign from suspicious masses, and we'll get into that a little bit more in a second. So big takeaway from this slide, or even from today, midline mass, think of an ultrasound because we're worried about thyroid. Lateral masses might want to be reaching for that CTA if you're worried about congenital neck masses, head and neck tumors, carotid body tumors, and even abnormal lymphadenopathy. It's going to be better at giving us more detail and higher diagnostic accuracy for those diagnoses. So I've already alluded to a lot of these things already, but with our history and physical exam, when these patients come in, we're already thinking older age equals higher malignancy risk, right? Anyone over the age 45, over 50, especially over 50, they're at higher risk, especially of those head and neck cancers, right? So moves the needle for our pretest probability a little bit higher if they're presenting with a neck mass. So always incorporate age and disease prevalence. Location we already touched on, right? Thinking of midline masses versus lateral masses. Duration, again, hammering through, is it acute, is it subacute, or is it chronic? When we're in the subacute or chronic territory, we might be a little bit more concerned depending on the clinical situation. And then those systemic symptoms, I've already mentioned a few of them, right? Of course, we know any unintentional weight loss, drenching night sweats, feeling weak, feeling, overly fatigued for no reason. And then any of those local symptoms, difficulty swallowing, ear pain, vocal cord changes, hoarseness. Dysphagia to solids usually starts with the head and neck mass, and it can progress to liquids if it's getting more significant. So any of those, again, it's really increasing your pretest probability for something more concerning here. Risk factors. So again, besides age, we're thinking of people with smoking history, tobacco use, history of head and neck radiation. And then for family history, specifically thyroid medullary cancer, right? That's our hereditary type of thyroid cancer. So if a bunch of people in that person's family, a sister, a brother, two aunts, an uncle, grandparents, have had that history of thyroid cancer, you might be a bit, again, more worried for that thyroid medullary cancer, and you'd want to work that person up. Consistency of the lump can be dicey because, even soft, mobile, painless lumps can be cancerous. But as a rule of thumb, I think, most of us know if it's, hard, fixed, painful, growing, again, probably moves the needle for our pretest probability to something more malignant or concerning. If it's soft, mobile, squishy, might be less concerning, but again, depends on the clinical situation. Again, if that person's presenting with systemic symptoms and the mass is soft and squishy, I'm still going to be concerned. So again, helps with our pretest probability, but sometimes can lead us astray a little bit as well. So back to our case, our 50-year-old female with a left-sided thyroid lump. It's been there for a couple of months. So as we know, thyroid gland pathology usually presents fairly chronically. It's hard, we can move it a little bit, and it is painless. She has no systemic signs or symptoms, no risk factors. She's feeling well otherwise. no family history of thyroid disease, and no personal, major thyroid disease or other conditions. So where do we go from here, right? We've all already alluded to, if we're worried about thyroid gland pathology, we're going to be reaching for that awesome thyroid ultrasound. We know it's fairly easily accessible, it's non-invasive, there's no radiation, and it is excellent at distinguishing benign from suspicious nodules. And of course, it's used to guide many procedures now, one of them being a fine needle aspiration if we need to biopsy that nodule. So again, when I was chatting also with a radiologist about tonight's presentation, and he mentioned, the thyroid ultrasound is very good for palpable abnormalities, but we want to be very careful and usually avoid if, don't order it if a person just has hypothyroidism, right? Treat the hypothyroidism, make sure they get better. We want to avoid in screening if a person's completely asymptomatic, even if they have some family history of certain thyroid cancers. We want to be very careful. We don't do universal screening because so many patients have benign nodules. Unfortunately, a lot of those benign nodules require follow-up. And then some patients will get unnecessary fine needle aspirations, further testing, sometimes surgery, right? And it all kind of stems from us being very judicious with our ordering. We're never perfect, but it's just really asking yourself, what's my pretest probability of disease? Am I gonna find something incidental that I really don't want to, deal with, or am I ordering it for a good reason, right? And I think we're all pretty darn good at that. And then for dysphagia, that's a dicey thing, right? Because if a person's presenting with dysphagia, but no palpable, thyroid mass enlargement, redness, we have to be very careful about ordering that thyroid ultrasound because dysphagia has its own entire workup, right? There can be oropharyngeal dysphagia, GI dysphagia, neurological dysphagia. So that could be a whole other talk, but just be very careful ordering thyroid ultrasound for dysphagia. There's better tests and a better workup for that, unless you feel a palpable abnormality or you're worried about a goiter. So just 2 cents for that. Radioiodine scans, really, I mean, I personally don't order these in primary care. I think they're more left to the specialists. We think about cancer staging, monitoring post, certain types of thyroid cancers, if we're worried about thyroid toxicosis. And then CT, in the words of the radiologist I spoke with, it's essentially useless for thyroid pathology unless someone has, a massive goiter or like a huge kind of invasive thyroid cancer that we want to use that CT to assess for compression on the trachea, retrosternal kind of invasion progression. So really limited for us in primary care. We don't need to worry about a CT for thyroid pathology. The thing with CT that's bothersome is that a CT is often ordered for a completely different reason, and then we find those benign, or any type of nodule on the CT scan. And you'll read that, dreaded comment from the radiologist saying, please consider a thyroid ultrasound. And we do have to follow what they say. So usually, these thyroid nodules are incidentally found, but our role in primary care is to follow up and make sure they're benign versus sinister. So given that palpable thyroid abnormality, very reasonable to order a thyroid ultrasound in this case, right? So a typical radiology report will comment on the size of the thyroid lobes, the thickness between the thyroid lobes, and then they'll describe any nodule that's worth commenting on. What I mean by that is any nodule that is cystic or spongiform is automatically benign. We know that cystic or spongiform nodules do not, cancerous cells or nodules in the thyroid gland are not spongiform or cystic, so we don't have to worry about those nodules. And in fact, radiologists will often not comment on those because they're automatically assigned as benign. They'll comment of the size of the nodules, of course, the location, composition, echogenicity, which we'll get into in a minute, margins, shape, and echogenic foci. So let's figure out what this means. And again, the radiologist will tell us what to do, but it's really nice for us to understand, why this person is being recommended for a fine needle aspiration. Why is follow-up imaging ordered, right? It gives us more diagnostic confidence for follow-up and management and when to really consult an endocrine. So we use the American College of Radiology TRADS scoring system. So what the radiologist does is he looks at those nodules and he comments on 5 features. And with those features, we're able to distinguish more benign characteristics versus sinister malignant characteristics. And they're all assigned points, right? So the lower the points, the more benign, the higher the points, the more concerned we are about cancer. So again, as I mentioned, cystic or spongiform, they're often not even commented on because they're automatically assigned TR1 or they're automatically benign. So what do these features mean exactly? Just kind of brief overview here. So the composition, again, cystic, spongiform, 0 points. We're not worried about cancer. Mixed cystic, solid or almost completely solid. That is more characteristics of a cancerous nodule, right? So our nodule in this case is cystic. It was automatically assigned 2 points. When we think of echogenicity, we think of the ultrasound waves and how much that nodule or tissue reflects the light or absorbs the light. So a tissue or a nodule that is anechoic means it's black, it's not reflecting anything. Isoechoic essentially means that the structure is sharing the same kind of brightness as surrounding structures. It can be a little bit gray or kind of blending in with the surrounding structures, and those are assigned a 1 point. That's our nodule here. Hypoechoic, less reflection, they're usually gray, and then hyperechoic, they're reflecting a lot of those ultrasound waves, so they show up as white. So general rule of thumb, hypo or hyperechoic share more concerning features when it comes to the thyroid nodule. Whenever you see a taller than wide nodule, or like already be flagged, that's a concerning feature. It shares characteristics of a more, cancerous appearing nodule, so be weary of that. Margins, so if they're smooth or ill-defined, we're not as worried. If they're lobulated, irregular, they get assigned higher points. And then lastly, echogenic foci. So our nodule had none, but sometimes they present with microcalcifications, peripheral calcifications. And again, those are characteristics that are increase our pretest probability of more of a cancerous concerning nodule. So the lower the points, the happier we are, the higher the points, the more concerned we are about malignancy. So inside scoop, again, I was chatting with the radiologist, and as we know, sometimes nodules aren't commented on, they aren't described. So which ones are commented on? What's worth commenting on? So ACR TRADS advises that, they shouldn't be reporting on more than 4 nodules, and they pick the nodules with the highest scores. Because when we think about it, we're not going to biopsy 8 nodules in the thyroid gland. It's not going to change management. We want to biopsy those nodules with the highest risk scores, the ones that are highest risk of cancer, because we'll be able to figure that out on the biopsy and look at those cells. Biopsying, several other nodules isn't going to help, and it puts that patient at risk, and it's ridiculous. We're not going to biopsy 8 things. So secondly, they also recommend that no more than 2 nodules with the highest scores should get that biopsy. Again, because we're looking for the most suspicious nodules, that will be enough to give us the diagnosis. We don't need to go biopsying all of them, even if some of them have fairly high scores. So like I mentioned before, with the solid composition, we get 2 points. With an isoechoic echogenicity, we get 1 point. This is a TR3 nodule, which we've probably seen a ton of these in practice, and they do require serial ultrasound commonly, sometimes a fine needle aspiration. So what happens next? With these mildly suspicious TR3 nodules, we want to follow up if it's 1.5 centimeters or more, which it is. So in this case, we'll want to order an ultrasound in 1 year because the risk of malignancy, as I pull up my table here, is around 4.8%. So we don't want to let this person slip under the radar, but the risk of malignancy is fairly low. We're comfortable to wait a year. Because it's pretty small, we don't need a fine needle aspiration at this point. And again, this table's fairly busy, but it's up on the blog if you want to refer to it later. But it's nice because it puts things in context. It makes us think, okay, why do some nodules get ultrasound and some get fine needle aspiration? It's because we know those nodules with more suspicious features or characteristics puts that person at increased risk of malignancy. So when we get into that TR4, TR5 territory, you can see the risk of malignancy increases quite substantially, and our index of suspicion goes up. Our pretest probability of cancer goes up. So we want to be following those people up more closely, ordering the fine needle aspirations, even with smaller nodules. So it puts the rationale of management into context, which is really nice. And that's from the American College of Radiology, which is synonymous with the Canadian guidelines as well. So, we open up our inbox, we're in primary care, maybe we're taking over this patient and we see this thyroid ultrasound, is due pop up, which we get a lot of, I'm sure. We can see the previous size here. We know we need to repeat that ultrasound. And with the updated ultrasound report, we can see that it's grown fairly substantially, so we don't love that. Still solid and isoechoic. It's still kind of, at that TR3 category. It's not overly suspicious. We don't love growth, and this is an older female, so our pretest probability is creeping up a little bit. We might want to keep an eye on this a little bit more, or we might want to do a fine needle aspiration, right? So what is considered significant growth, or what is considered significant when we follow up on these people? First off, if the TRAD score is increasing, let's say this nodule was suddenly taller than wide, it gets an extra 3 points. We're in that territory of we're worried about cancer. If the scoring points, are stable, but it's grown, then this is what, the radiologists essentially follow. If there's been a 20% or more increase in at least 2 nodule dimensions, and at least an increase of 2 millimeters in those dimensions, then that warrants, that is considered significant. We know that will increase our pretest probability of cancer. Cancer likes to grow, right? We know that. Cancer doesn't just shrink and go away. Bad things always get worse, which is my motto. Secondly, they look at whether there's been a 50% or kind of a doubling size in volume. So those 2 metrics are considered significant. And again, the radiologists are really good at saying what you should do next. And if I have any doubt in my mind, sometimes I will just send a fax back to that radiologist to clarify a few things, and that can be very helpful as well. So there is that significant growth. It's still classified as a TR3, but if we, based on this, significant growth, we want to go for that fine needle aspiration to make sure this isn't kind of gotten into the more cancerous territory. So if it was minimal growth, or it had stayed stable or even shrunk, which we see commonly, we still would have, repeated that ultrasound at year 3 just to make sure, again, we're keeping tabs on it, it's not growing. And typically we like to follow up with these patients. Are they having new localized symptoms like dysphagia, hoarseness, vocal cord changes? That kind of changes our clinical picture entirely. So we always have to match these numbers and the follow-up scans with the patient, of course. Are they still feeling well? Do they have any new symptoms? These are important things to review with them before you go ahead and order fine needle aspirations and other tests. So for fine needle aspirations, I mean, it's really going to be dependent on where you work and what you have access to. So of course, our endocrinologist can do the fine needle aspirations, but sometimes they hard to get a hold of. It can be months of waiting. Of course, they'll triage more urgent things. But there are some interventional radiologists that will do these ultrasound guided fine needle aspirations. So I pulled up this requisition, My Health Center. This is one actually in the Toronto area, and I was happy to see they provide ultrasound guided procedures. Now, I work in London. I know that My Health, I don't think, people can correct me for sure, they do ultrasound guided procedures, but it is another specialist that you can call on if you're able to, or maybe if the patient's willing to travel, if you're getting, a long wait time with that endocrinologist. And I do believe, some family doctors, I know, particularly in the US, do fine needle aspirations for thyroid nodules. So just something to keep in mind there. So we go ahead and order that fine needle aspiration. It's reasonable to do. This is a fairly common and very reassuring result to get. So we have numerous benign follicular cysts, lymphocytes, scant colloid material. That word benign is usually a very good thing. We don't have to worry about it. they have the TRADS criteria, and they also have another, rating and point system for fine needle aspiration results. So looking at that cellular material, they assign it a point system. So the Bethesda classification for fine needle aspiration, again, very busy slide. I'm not going to get into it in detail, but unfortunately, sometimes we get that result, that dreaded result back that says, we didn't get enough material. We don't know what happened. We need to repeat this. So that's when you get the unsatisfactory or non-diagnostic results, similar to what we get for PAPs sometimes. We really despise those. So unfortunately, you generally need to send that person back for a fine needle aspiration. In this case, it's benign. There's benign follicular cells. We don't need to worry. The jury's kind of out. I think there is some updated 2025 American guidelines for sure on, how often to follow up with these benign fine needle aspirations. They vary from 6 months to 12 months to 18 months. So there's variability on when to do that. The radiologist, the endocrinologist are usually pretty good at commenting on what to do for those situations. But when in doubt, consult your endocrinologist, right? Then we have the atypia of undetermined significance, going all the way up to follicular neoplasm, suspicious for malignancy, and malignant. So with that atypia of undetermined significance, depends on what we have accessible to us where we work, but either they'll repeat that fine needle aspiration and re kind of assess those cells, or there's molecular testing that can further differentiate whether these are more looking like cancerous cells or if they're more benign appearing. The hemithyroidectomy or thyroidectomy is very rare at this stage, but again, we consider that patient. Do they have risk factors? Do they have localized symptoms? Are we more worried about cancer? Should we take this gland out? Usually not, but always considering the clinical case. And then when we're getting into those higher risk scenarios, sometimes that endocrinologist will choose, they'll talk about a hemithyroidectomy or near total thyroidectomy because that cancer risk is much higher. So there's a lot we can kind of talk about even for thyroid cancer management, et cetera, but kind of beyond the scope of tonight. So really some take-home points for approach to neck mass and imaging. Thyroid ultrasound's best used if you have that midline neck mass or goiter, enlarged thyroid gland, and if you can palpate an abnormality, we're fairly concerned about that. Avoid ordering again if there's abnormal thyroid tests or if it's for screening. Be very careful with that dysphagia workup again. It kind of has its own clinical pathway for tests to order and what to do based on the clinical scenario. But certainly if that person has a palpable thyroid abnormality and there is dysphagia, very reasonable to order that thyroid ultrasound. Last, thyroid ultrasound plus the TRADS criteria is very good, has very good specificity and sensitivity for detecting thyroid cancers. So low risk of false negative results. But as we know, there's a high risk of false positive results or those incidentalomas, if you will. Lots of benign nodules that warrant follow-up. So again, we just have to ask ourselves, what's our pretest probability for thyroid disease? Is this test going to change my management? What am I going to do with a false positive result and a false negative result? It's nice sometimes to stop yourself and walk yourself through those pretest probability questions to make sure that we're ordering appropriately. And then again, midline masses, very reasonable to go for that ultrasound. Lateral masses, typically best suited for a CT with contrast because of, again, those etiologies that we all discussed earlier. So I felt like that was a bit of a whirlwind. Again, there's a blog post that's on NP Reasoning right now. If you have any questions, please feel free to email me. If you guys have questions tonight that I can't answer, I have people that can answer it for us, and I'll send up a follow-up email. And then again, if you aren't tuned into the NP Reasoning newsletter, I like to do these deep dives and provide education and key take-home points for NPs because we're an amazing profession, we're a growing profession, we're a strong profession, and we can all kind of work together to increase our diagnostic accuracy and confidence, right?